Our next speaker, I've fortunately known for quite a while. He was the clinical director of the largest practice we ever built in Maryland, and now I think he has 2 or 3 offices of his own, and he's done a phenomenal job. He understands managing associates better than probably anybody, because he managed, about 100 of them or something? 50? And did a really, really good job with those guys. It's Dr. Todd Bickling from Maryland. Give him a great, great round of applause if you don't mind, and welcome him. Listen very carefully. He's got a lot of great things to say.
Thanks, John.
Thanks, Bill. See you
Thanks,
tonight,
yeah. All right, mic on? Everybody hear me okay? All right. By show of hands, who here has never seen me speak or doesn't know who I am? Show of hands, hands up. Oh, great, a lot of new people. You guys are gonna love me. You're in for a treat. I'm Dr. Bickling, like John said. Let me grab the thing here. I'm the CEO of Strong Smiles Dental Care. I own it with my partner, Dr. Victoria Yu. We have 2 locations in Maryland. We're open 7 days a week, extended hours, 7 a.m. to 7 p.m. And so, yeah, I've been with chrisad since 2002 in some capacity. So I've known John and Corey for a long, long time. Doctors. How many doctors in here have associates? Can I see? Show of hands. Oh, good, quite a few. So doctors, I want you to tell me if this sounds familiar. You're sitting in your office, and your associate walks in like this. Hey, doc, I just sold a $20,000 case, right? Or popping, or whatever they do these days. And so what's the first thing that comes out of your mouth? Did they pay, right? So, oh yeah, they paid the treatment planner's in there right now, but they're ready to go. They were nodding, they were all fired up, they want to get this done. You say, okay. And then you look up, and what do you see? You see the treatment planner walking that patient right out the front door. And you go out to the treatment planner, you're like, huh? Happens all the time. Treatment planners, where's your treatment planners? Raise your hand. Tell me if this sounds familiar. Your doc comes to you. I got a big case, it's sitting in the chair, it's $20,000. You're gonna go in there, you're gonna sell it, it's all good. Patient's fired up, they wanna get this done, they're nodding, they're ready to go. You walk in, slide that little piece of paper across the table. Patient takes one look at it. Oh, hell no! Doc comes to you and says, what'd you do? You ruined it. Patient was ready to go. That sounds familiar. Give me an amen. So this is something that sounds like we have some similarities. So as John mentioned, at one point I was the boss of 50 doctors. I currently have 5 associates that work for me. And I have found that there's a disconnect between what doctors perceive and what patients perceive. And when that disconnect happens, nothing good occurs. It's just a matter of time before the patient walks out the door and gives us the 1-star review for being the greedy, evil dentists that we are. So that's what we're going to get into today. So I don't practice dentistry anymore. I stepped away from the chair in 2016. I was a practicing dentist I'm going on 20 years, but I stepped away from the chair in 2016. In 2016, I was working about a day and a half a week. And at one point, it occurred to me. I'm sitting down, I'm drilling on a tooth. And running businesses, it's stressful, and associates are stressful, and everything's stressful. And I'm drilling on this tooth, and this calm came over me. And I'm like, this is a piece of cake. I love just drilling on this tooth. This is my Zen moment, just drilling on this tooth. And I thought to myself, wouldn't it be wonderful if all I had to do from a job was just drill on teeth? Like a little tooth walks in the door, jumps up on my tray table. Hey, doc, I'm broken and got an infection. Can you fix me? Sure, tooth, not a problem. So I numb them up, do a little drilling, get an impression, make him a little zirconia hat. Thanks, doc. And then he jumps down, he walks out, pays with his little tooth credit card, and he's out the door. Like, how awesome would that be, doctors? I mean, you could do that 100 times a day, right? At $1,000 a pop, that's a $100,000 a day. Work 2 days a month, you know? And then I get up from that, seeing that patient, and I go into my office, and then I have to deal with everything else. Unfortunately, that tooth does not just walk in the door by itself. That tooth is typically attached to a person. And I view that person as the bouncer. And I got to get past that bouncer if I want to get to that tooth. And so then I thought to myself, how much of my day is spent dealing with the bouncer? How much of your day is spent dealing with patients, with their fears, their anxieties, their questions, their psychoses, their objections, all the excuses, what they read on the internet? How much of your day is spent dealing with that? I mean, think about it. 40, 50, 60% of your day or more? So I thought, man, a lot of my day is spent just dealing with the person as opposed to just drilling on that tooth, that simple, easy world that I want to get to. So I thought about it one more time. I thought, how much of my education went towards drilling on tooth? Pretty much all of it, right? Think back to dental school. Everything you learned was how to fix that tooth. Think back to all your CEs that you've taken. Probably dozens, if not hundreds, of possibly thousands of hours of CE, how to drill on that tooth. But how much of your training has gone into dealing with that person, dealing with the bouncer? Probably none, right? So we wonder, why is working on the tooth so easy, but dealing with the person so difficult? I just came up to it. I got to start learning something. I got to start doing some training. And I've come across lots and lots of issues. Some stories I'll tell today with regard to this disconnect between what the doctor perceives and what the patient thinks, and kind of give you guys some solutions. And that's what I'm here for today. So it's a long-held statistic, or a very commonly believed statistic, that only about 25% of diagnosed dentistry actually gets treated. I've heard this from people like Fred Joyle from 1-800-DENTIST, Howard Foran. I've seen this empirically, so I have no reason to disbelieve this statistic. But if you think about that, it's pretty terrible. That means that 75% of the necessary dentistry that's out there is not getting done, just walking around out on the streets. And these are the people that come and see us. Right? This is not to mention the people that just never even come in your door in the first place. 75% of the necessary dentistry is walking around out there not getting done. And I think that's terrible. Especially, think if we were any other business. Think of the rigmarole patients have to go through to come into your practice. They have to give you a call, make a reservation, get dressed, get in the car, drive to your office, show up on time, get seated in the chair, have you poke and prod them. You tell them what they need. Yeah, sounds good. And then, can I just get 25% of that done, please? Think if this were any other business. You call up a restaurant, make a reservation, get dressed, get in the car, drive to the restaurant, show up on time, get seated. Waiter goes over all their options. You say, that's great. I just want to get 25% of the food that you're about to serve me. What if your car tires are bald and you need 4 new car tires? You're going to show up and get 25% of the, can I just have 1 tire, please? You call up the eye doctor, make an appointment, get dressed, get in the car, drive to the eye doctor. Can you just do this side of this eye, please? It's terrible. It's terrible, this statistic. And at Strong Smiles in 2018 through July, our case acceptance was only about 17%. In other words, for every $1 that we treatment planned, we only collected 17 cents out of it. It's terrible, terrible. And it was just racking my brain. And so, chrisad has said, you may have heard this with John this morning, as the out-of-pocket cost increases, case acceptance plummets. And I don't disagree with this. I've seen it empirically. And I believe that part of the reason is simply because once the patient has to start paying for it, they don't believe you anymore. It's when the doctor's in there talking to the patient about all the benefits of the stuff they need, and they're going, yeah, sounds good. They're not thinking about the money. But as soon as they have to pull that wallet out of their pocket or out of the purse, the psychology changes. And that's where that disconnect is, and that's the thing that we're going to help with. So chrisad has said, and you've heard John say this morning, he said, unless a patient has a perceived problem, do not give them a treatment plan that exceeds their insurance maximum. And I heard that, and I'm like, what? I can't not give them the treatment plan. They need it, right? A non-diagnosis is as good as a misdiagnosis. So I had a problem with this. I'm like, and plus, if you had seen one of the slides he threw up, he went by it real quick. I wish he would point it out. My name on one of those slides was, when I first started at Strong Smiles, I was the only doctor there. And I was producing almost $2,200 per filled hygiene appointment. That's about 3 times the national average. So in my mind, this stuff is not making sense. If a patient needs it, they need it, and I'm gonna figure out how to get them to say yes to the treatment. But once we became an associate-driven model, it didn't quite work out that way. We went from 3 times average to well below average. And so I was forced to have to figure this out because we had a terrible, terrible year in 2017, and I had to figure this out. And so I have no problems with our doctor's treatment plans. I have very little problems with our associates, the way they treatment plan. But just because they're right does not make the patient like them, and doesn't mean that the patient's gonna say yes. I feel like I've been ignoring you guys, so I'm gonna come over here for a little bit. So finally, I broke down. Even though I've been with chrisad in some capacity for since 2002, finally Matt Pryor and Sean said to me, what's your new patient retention rate? And I'm like, I don't know. I'd have to track that manually, and I don't want to do it. So I did. I went back from July, and I went back 6 months. And then I took roughly the 3 months prior to that, so November through January, so January 20th. And I found out that in our Edgewater location, we had 241 new patients. In our Odenton location, we had 194. And I'm excluding military because our Odenton location is very near Fort Meade, and they send us military patients, and they kind of come on a one-time basis. We probably had another 100, 120 military patients. So I'm just using patients that came in via normal means. So of those 241 and 194 new patients, I then tracked how many of them came back a second visit. How many came back for a second cleaning, whether it be a 3-month cleaning, 4 months, 6 months, whatever. And this is what I found. Our Edgewater location lost 98 of those 241 patients, which we had a 59% new patient retention rate. Horrified, I didn't even know this was happening. Odenton lost 105 of the 194. So 46% retention rate. I was mortified when I saw these numbers. So then I started to break it down. I said, all right, who's the guilty party? Who's the guilty associate? I wanted to say which patient saw which doctor. So associate number 1 in Edgewater was responsible for 33. Associate number 2 was responsible for 30. Associate number 3 was responsible for 32. And let's head over to Odenton. Odenton, associate number 1 was responsible for 46, and associate number 2 was responsible for 45. Now, the next one I'm going to show you, Dr. Victoria Yu is practicing part-time in both locations. She was responsible for 7. She's an owner doctor. So I see they're all equally kicking patients out the door, more or less. So then, chrisad says, if they're not perceiving a problem, don't give them a treatment plan above their insurance maximums. So let's say, all right, chrisad, put your money where your mouth is, let's figure it out. What was the average treatment plan cost per patient that we lost? Associate number 1, $2,200. And by the way, this is patient portion, this is out-of-pocket portion. Associate number 2, $3,600, $3,900, $3,800. $4,400. And Dr. Yu, who is a very high producing dentist, her was $10,793. So it takes a lot for Dr. Yu to kick a patient out the door. So I started to think, chrisad might actually be onto something. I might be standing firm in my principles, thinking that I've got to present these treatment plans to patients. In the meantime, they're just leaving. They're just leaving. So then I thought about it. I said, each of these doctors, with the exception of Dr. Yu, only has the ability to sell a certain number of dentistry, a certain amount of dentistry. Beyond that, their personality or their communication style cannot support that level of treatment planning. So now I say to my doctors, your treatment plan is biting off more than your personality can chew. So we had to come up with a name for this dollar amount. So I called it the likability limit. So that's how likable you are. You're $2,200 likable. Each of our doctors, they have their own, I thought that was a little mean. So this is their personality plateau. Doctor, your personality plateau is at $3,800. This is your sales ceiling. You are not allowed to sell above $3,700, doctor. Your communication cap, whatever you want to call it. Finally, we ended up, this is the danger line. So doctor, this is your danger line. And each of our doctors have their own danger line. And we're going to track this, and we're going to update their danger line or their danger zone every quarter. So at the end of October, I'm going to go back. I'm going to do the same thing. I'm going to go back 6 months, track the 3 months prior to that, see how many of those new patients that we lost, find out what the average treatment plan case was, and then, doctor, that's your new likability limit. And you know what we have found? I don't have the exact number in front of me, but since we've been doing this, I have never seen, and we track our case acceptance by the week, I've never seen a week where we've collected less than 30% case acceptance. And in many cases, it's 40, 50, 60% for an entire week. It's 40, 50, 60% of a smaller number, but it's a bigger number on the other end. And now we have a happy patient that hopefully we're going to see again in 6 months. So that's how I got that across to our doctors. I just showed them the math. We're doing, instead of doing 17% of X, we're doing 50% of Y, even though Y is a smaller number than X, and it ends up being a bigger number in the long run, and we have a happy patient, and we have a happy customer. I'm going to briefly just go over, I'm not saying we don't diagnose it, and I'm not saying we don't tell the patient that they have more work to do. We just briefly go over the big picture, and then we narrow ourselves in on the things that are most important. Hopefully that stuff falls below the danger line or the likability limit. So that's one of the things that we implemented. And again, I've been working with chrisad for 18 years, and I just started this 3 months ago. So every time I come here, I learn something new. I hope you guys learn the same thing, learn new things as well. And then I looked at what was the average treatment plan of the patients that we kept. Look at the number, $1,600. Right at their insurance maximums, isn't it? So anyway, I couldn't argue with the logic, so we had to implement it, and we did it, and actually it is working for us. So just wanted to throw that out there for you guys. So it doesn't matter, doctors or associates, if your treatment plan is correct. It doesn't matter if they need $20,000, $15,000, $10,000, $7,000 worth of work. If your treatment plan is biting off more than your personality can chew, you're just kicking them out the door, right? And they're just going to go on Yelp, and you're the greedy, evil dentist that all you want is their money. And I really kind of came across this with this patient, Kimberly. I ran into Kimberly back in 2009 or 2010. Kimberly was seen by an associate of mine back when I was working for a larger corporation. Kimberly was seeing a doctor in our Prince Frederick office that I would call her shy. I would not call her aggressive. I would call her conservative, almost to the point of being timid. She would almost never do crowns. She'd do MODBO, XYZ, composites. But the reason why I found out about Kimberly was because this doctor was reported to the Maryland State Dental Board for overdiagnosis and aggressive treatment planning. And I'm like, wait, Dr. Timid? Aggressive treatment planning? She's anything but. So I get called in, check it out, what's going on? So the first thing I do is I pull up the x-rays. We look at the pano. Well, you can see Kimberly's got some large amalgams in the back. So first thing in my mind is, if that were me, maybe those things are the doctor treatment plan crowns on all those, I don't know. But not Dr. Timid. Why would Dr. Timid do that? You can see there are some class 4s up front that need to be repaired, so I can see that. And if you look real close on tooth number 20, kind of on the distal occlusal there's little shadows. There might be something there. All right, so then let's go to the bite wings. All right, here we go. I see it. So there's some caries here on the mesial of 2, some incipiencies, you know. Then I look at the treatment plan. She diagnoses, can we go back one, please? Thank you. So she diagnoses tooth number 2 as needing a buildup in crown. Right, I can see that. I never saw the patient, but I can see that. Watch, watch, watch. 4 class 4s across the front and a DO on number 20. It was a $2,000 treatment plan, of which the patient's insurance covered $1,500. So it's $500 out of pocket. I'm like, wait, this is $2,000 treatment plan, and the doctor was reported to the Maryland State Dental Board for aggressive overdiagnosis. In my opinion, that's conservative. What is going on? What am I missing? There's a disconnect here, a complete disconnect. So I had to look for some clues. So I pulled out the health history here, and what do we find? Well, the first thing is we find out Kimberly's 24 years old, and she lives at home with her parents. If you notice, her address is the same as the responsible party's address. It's the same, and that responsible party is her father. So 24-year-old living at home with mom and dad. Oops. Her last dental visit was 1 year ago. Are you experiencing any problems right now? Any problems? No. Reason for visit? Cleaning. It turns out that Kimberly's father was a state police officer, Maryland State Police officer, had just recently retired. Oh, sorry. Previous dentist was in Hagerstown. Oops, I'm sorry, can we back up one more time? Previous dentist was in Hagerstown, Maryland. Hagerstown is about 3 hours from Prince Frederick. Turns out Kimberly's father was a Maryland State Police officer, just recently retired, moved from Hagerstown, Maryland to Prince Frederick. We accepted their insurance. We're open 6 days a week at the time. Give us a try. What the doctor didn't know was Kimberly was seeing the same dentist in Hagerstown for the last 15 years. And her last dental visit was 1 year ago. What do you think that previous dentist said to Kimberly 1 year ago? Everything's fine, you're doing great. And oh, by the way, and so the doctor didn't even realize it, but she's walking into a trap. It's a trap. And so Kimberly's sitting in the chair, and by the way, mom, 24-year-old, mom is sitting in the operatory with her. Doctor walks in, looks at the x-ray, does the examination, tells Kimberly she needs all of these fillings and this crown, and guess how mom reacted? Not my schnookums. Right? It's that disconnect. So then I realized I'm missing something, the doctor's missing something. We have to figure this out. How can there be that big of a disconnect between what the doctor sees and perceives and what the patient perceives? And then I realized, after doing some study, and some of this comes from Paul Homily. If you haven't read anything by Paul Homily, he's made some of the biggest change in my life. But some of what I'm about to tell you comes from Paul Homily. I've added some things to it. But I figured out there's 2 things that we were missing. Anybody know the significance of this slide? So this is one of those stereograms from the 1990s that if you like cross your eyes, like the 3-dimensional image comes up. It was the cover of Remember 2 Things from Dave Matthews Band. So if you look, cross your eyes, you'll see like a little peace sign. Look at all the crossed eyes out there. Awareness and concern. They're 2 different things. So all of the dentistry that is in somebody's mouth, well, first we have to find out, are they aware of it? And second, do they give a crap? All of the dentistry that's in a person's mouth is going to fall into one of 4 categories. They are either going to be aware and concerned about it, unaware but concerned about it, aware but unconcerned, and unaware and unconcerned. So let's go through them one by one. Aware and concerned. Hey doc, I was riding my skateboard, hit a tree, broke my front tooth. It's flopping around like this, it hurts, and I look ugly. Can you fix it? They're aware of the problem, and they're concerned about it. What do you think the likelihood of case acceptance is? High or low? High, right? Aware and concerned, high case acceptance. Unaware but concerned. Hey doc, I got a toothache. Don't know where it is. Could be top, could be bottom, could be front, could be back. I don't know, but it hurts. I want you to fix it. They're unaware of what's going on, but they're worried about it, concerned about it. What do you think the likelihood of case acceptance is? High or low? High. All we do is we get an x-ray, diagnose it, tell them what's going on, and in doing so, we now make them aware and concerned. High case acceptance. Aware but unconcerned. Mr. Jones, I see you have a missing front tooth. Tell me about that. It's been missing for 20 years. I chew my food just fine, and I'm still cute. He's aware, he knows it's missing. He just doesn't give a crap. So what do, right? We give him a $5,000 treatment plan. We give him a $5,000 solution to something that he doesn't perceive as a problem. There's your disconnect. Hygienists. How many of your patients walk in like this, have no clue what's going on? No, none. You tell them about it, you do the probing, you show them the x-rays, all the little barnacles on the teeth, right? You explain it, show them all the gums and the buildup, and they're like, yeah, can I do whitening? Can I do? It doesn't hurt them. They don't give a crap. So what do? We offer them a $1,200 option. It's going to take 2 visits. We're going to have to numb you up to something that's not a problem in their mind. There's our disconnect. In these last 2 cases, what's the likelihood of case acceptance? High or low? Low. So all the dentistry that is in a person's mouth, it's going to fit into one of these 4 categories. Okay? And you can come up with your own examples. Next time when you get back to work, ask your staff. Come up with examples that would fit into these categories. You can come up with your own examples. But the dentistry that people walk in with, it's going to fit into one of these 4 categories. And this is a very important point. So if you're sleeping, please wake up. Or if somebody next to you is sleeping, please wake them up. We were taught in dental school that the way you sell dentistry is by educating patients. You need to raise their dental IQ. Anybody hear that before? This is an important point. Educating patients only serves to raise their awareness, not their concern. What do I mean by that? If I take this patient here, who we said has a high likelihood of case acceptance, and we educate him, we just move him that way. Now he's an aware patient who's concerned. He was saying yes before, he's saying yes now. If we take this patient who doesn't give a crap, didn't know that it's going on, and we educate them, we just move them that way. Now they're an informed patient that doesn't give a crap. He was saying no before, and he's saying no now. And if we keep talking, this is what patients see. Blah, 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 blah. Can I just get out of here? It's even worse. Doctors, think back to dental school. I went to Tufts Dental School. When I was there, it didn't have like this part. It was just like there. But if a patient wanted to come in as a regular patient, they could walk to those front doors, and I'll never forget this. You remember that patient chart? It's like 13 pages long you gotta fill out. And what are the first 6 pages? Perio, right? You gotta get perio checked off before you can start doing the real dentistry, right? Perio. We are basically trained to, first thing, and we do it now. I mean, all of our new patients basically come in through hygiene, right? We're basically trained to go right to the area that is probably they're least likely to be aware of and least likely to be concerned about. We're trained to do that. So one thing I might suggest is instead of going right to the things they don't care about, start first with the things that they are aware of and that they do care about. I didn't say don't talk about perio. I said don't talk about perio first, right? Because what better way to instantly build a disconnect than going to some place that they have no awareness that it's going on and they don't give a crap. Start with something that they're aware of and concerned with. Won't that put you kind of on the same page with the patient? Isn't that step one in building trust? Isn't that step one in building rapport? So start there. Start there and then move over to this one. And then spend very little time here and here. So when you're giving them the big picture, you're talking very briefly about the stuff that falls into these categories. You start first here, then move to there, and then there, and there. And spend very little time down here. And do not, this is the stuff you don't want to give those big treatment plans on stuff that they don't care about. So we've said that these people up here, they're already saying yes to the treatment, high likelihood of case acceptance. And these guys down here, they're saying no or not right now, low likelihood of case acceptance. So between awareness and concern, which do you guys think is more important in case acceptance? Concern. And if you read any sales book ever, you will know that people they purchase based on emotion. And then they justify it with logic. Well, isn't concern an emotion? And isn't awareness logic? They've already made up their mind. And when we educate them, it doesn't make a difference. If they've already said yes, the education we give them just reinforces it. If they've already said no in their mind, the education we give them just kicks them out the door. The problem is, so we don't want to move them from here to here. Educating a patient just moves them from here to here. And by the way, I'm not saying don't educate your patients. You do have to educate your patients. You have to, morally, ethically, legally, you have to give them enough information to make a reasonable decision. But you don't have to give them a DDS, right? And understand that educating patients has no bearing on whether they say yes or no. None. It just moves them from here to here. You still have to do it. I still educate my patients. I get carried away sometimes. But I understand that has no bearing on whether they're going to say yes or no. That just moves him from here. We need to move them up. We need to move this guy up here and this guy up here. We need to raise their level of concern. We need to raise their level of emotion. We need to move them up. That's what we need to do. So how do we do that? How do we raise somebody's level of concern? And the answer is you can't. I didn't say I can't. You can't. Concern is an emotion. It's a subjective emotion, and it's the patient's emotion. You really can raise somebody's level of concern. And I love Justin Koch when he spoke out in Las Vegas. And he may say this again, and I'm sorry if I steal your thunder, but he talked about sales, and he talked about sales as a transference of emotion. Justin, did I ruin it for you? Okay. It's a transference of emotion. That's why I can sell dentistry. I can get somebody emotional. And it doesn't matter what the emotion is. It could be happy, sad, anger. Some of my patients, they hate me. But I'm effective. You can't be a teacher, though. You got to be a leader. You got to be able to transfer that emotion from your gut to their gut. Let's understand, avoiding dental treatment is necessary dental treatment. It's just not logical. It doesn't make sense. If a patient walked into your office and they had a broken thumb and it's just dangling there, and you say, hey, I can fix it, make it work and look good as new. It's going to cost $1,000. You think they're going to say yes? Yeah. You have a bubbling pus volcano on your hand. It's just oozing pus. I can fix it. It's going to make it look and feel like normal. It's going to cost $1,000. You're going to fix it? What are they going to say? Yes. But as soon as it's in their mouth, no, too much. So it's not logical to avoid dental treatment unless you're a hockey player. Then it makes sense. So we need to raise them up. We need to get them from unconcerned to concerned. But here's the problem. There's a barrier. There's a barrier keeping their brain from working. And that barrier is right here. They are not going to go from here to here until we get past that barrier. And that barrier is called the objection. They've got an objection. Their brain has an objection. And it's an emotional objection. Doesn't matter what you do, they're not going to get past it. Doesn't matter how much you explain it. They're not going to get past that objection. It's an emotional objection. There are 3 steps in overcoming an objection. This comes from a sales book. This comes from Grant Cardone. 3 steps in overcoming an objection. Anticipate it, validate it, and eliminate it, right? And the easy thing about dentistry, there's only 4 objections in dentistry. People avoid dentistry for emotional reasons and emotional reasons only. Those emotional reasons are called the objections. And there's only 4 of them in dentistry. What are they? What's the first one? Money. Money is an emotional reason. And if you don't believe money is an emotional reason, you've never had a pimp. Or you have had a pimp. Fear. Fear is an emotional reason. It's in the name. It's fear. Time is an emotional reason. Raise your hand if you've ever been late for work. What's your heart rate doing, right? Raise your hand if you've ever been swamped at work. What's your heart rate doing? And it's not because of the amount of work that you have to do, it's because of the amount of time that you have to do it. Time is the emotional reason. And the last one is trust. I put this last. I actually think this is the most important one. Trust is gained early in the appointment. Patients are going to make up their mind whether they trust you in the first 30 to 60 seconds, just the first few moments of meeting you, whether they trust you or not. So if I were to put them in order, I would put them in this order. Trust first, then fear, then money, then time. And the only reason why I put time at the bottom is because we're open 7 days a week. We've already solved the time issue. There's nobody in my town that is open more hours than us. I can do a full mouth reconstruction in 1 visit, or I can prep 28 teeth in 1 visit. There's nobody that can solve time better than I can in my neighborhood. So if I were a dentist that were open 4 days a week, 10 to 4, Monday through Thursday, I would actually change the order. Because time then is an issue. I think money is the least important of the emotional objections. My opinion. I have no statistical data to back that up. It's my opinion. I think money is a fake objection. I think it's a fake objection. It's the one thing that patients tell you that you got no answer for because you're not going to pay for it for them. I think it's a fake objection. I think the big one's trust, followed by fear and time. So anticipate the objection. You know what it's going to be. It's going to be one of those 4 things. The next thing you do, validate the objection. Patients' objections are usually based in reality. So it should be instantaneous, knee-jerk reaction. When a patient raises an objection, the first thing you say is, you know what, you're right. Man, that's expensive. Yeah, you're right, it is. Oh, I'm afraid of the dentist. Yeah, me too. I am. I have a filling that popped out about a year ago. I haven't gotten done. Scared to death. Oh, it's terrible. You guys frighten me. So that's expensive. You're right, it is. I mean, I've heard stuff like this. I've heard my associates and other people say, it's not expensive. Think of it as an investment. Hey, what does that even mean? Like you pay $1,000 now, and a year from now it's going to compound at 8% interest, and now your tooth is going to be worth. What does that even mean? It's dumb. I'm afraid of the dentist. There's nothing to be afraid of. Disconnect. I mean, we're shooting ourselves in the foot every chance we get, right? Patient spills their guts, and we tell them they're wrong. Stupid. Their objections are generally based in reality, Yeah, $1,000 is expensive, right? But that's not the end of the story. We got to move on from here, and we move on to the third part, which is just get rid of it. Get rid of that emotional objection. So here's our barrier, money. That's expensive. You're right, it is. And by the way, you should do this with your staff. Train your staff. Bring up an objection, and if they stammer and go, they should instantly go, you're right, it is. You're right, me too. They should and if they don't do that, you have to train over and over and over again. I practiced this with my staff, and at first, they were terrible. But now, objection, you're right, it is. But then solve it, overcome it. Well, would you prefer to do less dentistry, maybe break it up in small chunks, or perhaps we could do monthly payments, which works better for you? Let's get rid of that objection. It's a real thing. Money is a fear. I'm afraid of the dentist. Yeah, me too. I understand. I got a filling. Needs to be replaced. Scared to death. We have sedation dentistry. I just don't want to sedate myself and do my own dentistry. I put empathy up here because empathy, what better way to transfer emotion from one person to another, right? Dude, I'm in your shoes. I feel your pain, right? Once they feel that transference of emotion, once they see in my eyes, I get it, I'm scared too, we start to become simpatico. Time. I mean, I'm telling you, where's Gio? Gio was talking about, some of his patients, maybe they just don't realize his convenience, right? They think it's going to take 2 weeks to get in to see him or something like that. Because that's how patients have been treated in the past. Maybe they don't know that, hey, come in this weekend. We'll get you done this weekend. Get it taken care of. You don't have to take off work. We'll get it done in one visit. We're open 7 days a week. Come in and see us. We're super convenient for you. Trust. Listen, empathize again. Empathy is so, I've been accused of not having empathy. I have a ton of empathy. I have no sympathy, but I have a ton of empathy. I can put myself into somebody's shoes. I don't want to get into sympathy, empathy thing, but empathize with people. Put yourselves in their shoes. Emotionally feel what they're feeling. But one of the easiest things to do, just listen to patients. When I was a young dentist, I used to talk a lot. I was the blah, 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 educating the heck out of patients. But then I learned to listen. And so now I tell my staff, these radar dishes here, these are my trust collectors. I use these to collect trust. Right? And how do I get my trust collectors to work? What do I have to do to get these things to work? I have to shut my mouth. Well, I have to ask a question, right? And then shut my mouth. Question. And then button it. To use my ears, my trust collectors. One of the things, if a patient's not getting the work done, again, let's remember, it's not logical, unless they're a hockey player. I just ask, empathetically, non-judgmental, hey, so what's your biggest concern about this treatment plan? What's stopping you from doing it? Non-judgmental, I just want to know. How can I help you get this done? Do you want to get started today? Like, that's the hardest close I've ever done. Would you like to get started today? That's my hard close. I'm not a hard sales guy. I'm a soft sales guy. You don't want to get started? Why not? What's going on? Tell me about it. Here's another objection. This one's not in your slides. Have you ever heard this one? I got to go ask my husband. Have you ever heard that? Raise your hand if you ever heard that one. Got to ask my spouse. So I'm going to tell you what to do. I'm going to tell you, first of all, I have to ask my spouse. I have to ask my husband. That's called a stall tactic. Okay? It's a stall tactic. I'm going to translate that for you. That means I have to ask my husband. That means I have an objection and I'm not telling you what it is. That's what that means. I mean, come on. It doesn't matter if you're a dude or a lady. Come on, ladies. You see a pair of shoes you like. You can't live without them. You're going to go home, consult with the husband. Dudes, you see that football jersey you like. You're going to go home, ask your wife, hey, it's only $300, right? No. I got to ask my spouse. Translation, I have an objection, and I'm not telling you what it is. So this is what you do. If somebody says that, you say, I completely understand. What do you think they're going to say? I have to go ask my spouse, completely understand. What do you think they're going to say? They're only going to say one of two things. Well, he never says no to me, so he's going to say, get it done. Great, let's get started. Or he's probably going to say it costs too much. Boom. You've just flushed out the objection and you made the husband the bad guy. Right? So, patient says to you, I need to ask my spouse. I completely understand. What do you think they're going to say? Flush out that objection and make the husband the bad guy. Right? He's going to say it's going to take too much time. I completely understand. Let's see if maybe we can do it for you this weekend. How's that sound? All right, flesh that out. So at this point, I would like a volunteer. And if nobody volunteers, I'm going to pick somebody. Microphone, somebody. All right, you with the white shirt. Yep, come on up. Yep, third row back right there. Yep, come on. Sorry, you don't look happy. I'm empathizing with you. I'm putting myself in your shoes emotionally. Yeah, up here, Mike. Listen. Please watch your step. You're not looking. You still don't like me, do you? What's your name? Marisha, come on up. Everyone, can Marisha, can you give her applause here? All right, is Marisha's mic working? Can you test it?
Hello.
All right. So what I train our doctors on, and Marisha, what do you do?
I'm an EFTA.
You're an EFTA.
Yes.
All right. So what we're going to do, Marisha, is we're going to have what's called a question-versation. What I do is I try to train our doctors on how to have a conversation with a patient, but using only questions. And so what you guys are going to notice is, I'm going to talk to Marisha, and the last sentence that comes out of my mouth is going to be a question. I'm going to stand on this side of you. Can you guys see over there okay? Over there, if we can come up here. So the last sentence that comes out of my mouth is going to be a question. I may give a little bit of information. I call that a leading statement or an informative statement. And then I follow it up with a question. And when I do the question, I'll do this. I'll go, that's a question mark. Right? So that way you know it was a question. Right? So what we're going to do is you're going to pretend you're a patient and I'm the dentist. Okay. And so what I'm going to do is we're going to interact. And we're going to play out a little scene. And this first scene, you're going to be nice. You're going to agree with me and be agreeable and be a patient that's interested in getting the work done. And in the second scene, you're going to not give a crap whatsoever. Okay, so we're going to do it. It's going to be a question-versation. Here we go. Hi, Marisha. I'm Dr. Bickling.
Hi, nice to meet you.
Nice to meet you. Get the microphone up there. Yeah. All right. So, Marisha,
Yes.
I noticed that you have a missing tooth.
Yes.
Tell me about that.
Oh, it's been missing for so long. I really want to get it fixed, but I just haven't been able to afford it.
I understand. So it sounds like that cost is the biggest factor. Is that correct?
Yes, sir.
Okay, great. So are you familiar with your options for replacing that tooth?
No, sir.
Okay, so we have three options, but before I go into them, first, do you prefer something that comes in and out or something that stays in place?
Oh, no. I do not want to have to go on a date and have to take it out or
I
anything like that. No.
completely understand. I used to have a partial denture when I was a teenager. I'd eat food and it came out. It's so completely understand. So great. Well, we have two options that stay in place. This one is called a bridge. Here's a picture of it, model of it. This one's called an implant. Okay. This one costs about $3,000 and I can have it done in about 3 weeks. And this one costs about $5,000 and could take up to 8 months. Is there one of these two that works best for you? Question.
I'm going to go with the cheaper option.
Okay, so the bridge sounds like that's the one for you?
Yes, sir.
Question. Okay, great. Well, we're going to go ahead and get started on that. And it was great working with you. I'm going to take great care of you, okay?
Thank you so much.
All right, that's a really good job, right? Now, Marisha's not going to give a crap. All right? She's not going to play nice at all. I'm going to ask a question. She's going to be like, I don't care. So, hi, Marisha. I'm Dr. Bickling. Nice to meet you.
Nice to meet you.
Okay. I see that you have a missing tooth. Tell me about that.
Oh, I don't have a problem with that at all. It's been like this for a while, and I'm really not interested in getting anything done.
I understand. It makes total sense. Would you like me to tell you about your options?
I'm pretty sure that the last dentist told me, so no, thank you.
Okay. And are you aware of any of the problems that could potentially happen of not getting it fixed?
I don't see why it would be a problem. It's just a missing tooth.
I see. Well, there are potentially some issues. I'm happy to go into them if you like. But if you're not interested, there's no reason for us to go any farther. Is that okay?
No, sir, I don't think I'll have the time for that. Thank you, though.
Okay, sounds great. Question. All right, Marisha, thank you for your time. Appreciate it very much. Everyone give Marisha a big round of applause. Great job. Thank you. So when a patient is not concerned, what do? They just don't give a crap. What do? You're like, okay. Later. thought you were going to kill me when I picked you. You're like, eh. I'm like, hey, you're still a good person. I'm still a good person. Let me know when it does bother you. You know, I have found sometimes when you let patients off the hook, they let their guard down. Because they're coming into you. They got the shield, right? Because your previous dentist told you all this stuff, was talking at you, and they got the shield up. And you're like, okay, will you tell me when? And they're like, what? Wait, what? You're just going to let me walk out the door? You got to get that shield down. Because they're ready for you to talk at them, right? Boom, boom. Your words are bouncing off my shield. Doc, get that shield down. By the way, that concept comes from a book by an author called Robin Dreeke. It's called The Code of Trust. He's a former FBI agent that had to get information from Russian spies. A great, great book. But it can be applied in dentistry. Robin Dreeke, Code of Trust, I think it's called. Got to get that shield down before you can get information in. And he goes over his strategies of doing that. It's a brilliant, 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 brilliant book. Paul Homily, as I mentioned earlier, was one of the most influential doctors. I never met the guy, but read his books, saw some things on YouTube. But in one of his books, one of the chapters is called When the Patient is Ready, the Dentist Will Appear. If you're not interested, let me know when you are. Okay? I'm here for you. You're a good person, I'm a good person, we're going to take great care of you. Oh, so whatever happened to that doctor that saw Kimberly? Well, the doctor was reported to the board, as mentioned, and let's be honest. Your state dental board is not out to protect you. They're out to protect patients from you, all right? So whenever they get a complaint, it is their duty to investigate it, make sure it's real. So they did some random chart audits on this doctor, said pick out this chart, this chart, this chart, this chart. And they went through, did their chart audits, and they agreed with the doctor on the treatment plan. Yeah, it's a conservative treatment plan. No problems with it whatsoever. But the other 4 charts that they found had issues. No diagnosis, no clinical notes, no radiographs, no supporting documentation. And so they ended up getting that doctor in trouble. Her license was put on probation. She had to go and take some classes, right? For something that wasn't even the complaint in the first place, and she was right with the complaint in the first place. Okay? So we got to get this through our heads. This disconnect is hurting everybody. It's hurting patients because they're not getting the necessary dentistry done, and it's hurting doctors because the patients are, at the very least, they're going and they're telling all their friends what a greedy, evil person you are. If not, they're telling the world on Yelp or Google or the state dental board. You know, I had a patient actually file a complaint to the board that I never met the patient. Never met the patient. One of my staff members upset him so bad, they filed a complaint about me. I was like, I was in a conference 3 hours away. So we've established that educating patients only moves them this way, only moves them this way, only raises their awareness, has no bearing on whether they say yes or no. You have to do it. You got to give them enough decision to make an informed decision. When I was talking to Marisha, we talked about the different dental options, didn't we? Something that comes in and out, something that stays in place. When we got to the point where she didn't give a crap, I asked her if she would like to know these things. She said, no, I can write that in my chart note. Attempted to inform patient of sequelae, blah, 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 blah. She wasn't interested. That goes in my documentation. But that doesn't make any difference on whether they say yes or no. We got to move them up. We got to transfer that emotion from us to them. We have to be a leader. We have to make sure that they're feeling that they need that dentistry, that feeling that's inside of us. Because they're not going to care how much you know until they know how much you care. Thank you very much.